Welcome to the Alabama Public Health Training Network. I'm Leanna Rambo, Newborn Screening Nurse Educator at the Alabama Department of Public Health. Thank you for joining us today for our program, Newborn Pulse Oximetry Screening to Detect Critical Congenital Heart Defects. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses expiring on June 20th, 2020, and 2 years for social workers expiring on June 30th, 2021. If you are watching this program on demand and want to receive a Social Work CE certificate, you will need to complete the Social Work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there's no Social Work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenters today. Dr. Wally Carlo, Associate Professor in the Division of Pediatric Cardiology at the University of Alabama at Birmingham, and Rachel Montgomery, Director of the Newborn Screening Program at the Alabama Department of Public Health. Welcome to you both. I know we have a lot of information to cover today, so let's get started with Dr. Carlo.
Thank you. So we're going to talk today about pulse oximetry screening for congenital heart disease in healthy newborns in Alabama. First of all, I have no disclosures. So heart conditions are actually fairly common in that 1% of babies in the United States are born with a congenital heart disease. 1/4 of these babies have what we term critical congenital heart disease. We would define critical congenital heart disease as a structural heart defect, usually associated with hypoxia in the newborn period, that could have a significant mortality or morbidity early in life with closing of the ductus arteriosus or other physiologic changes early in life. Importantly, it's estimated that 1 of every 25,000 live births is affected by undetected critical congenital heart disease, resulting in mortality. So newborn screening has improved morbidity and mortality rates for many conditions. We are most familiar with newborn screening as it is applied through newborn hearing screens and dried blood spots to detect rare disorders. As of 2010, pulse oximetry screening for critical congenital heart disease has been recommended by the U.S. Health and Human Services. Pulse ox screening is more similar to newborn screening in that both require investment in screening technology, training hospital staff, and having systems to track and communicate results. On the other hand, pulse ox screening differs in that there is in-hospital testing and in-hospital follow-up as opposed to the post-discharge follow-up that is done for a failed hearing screen, for example. In this table, which I apologize for the small print, comes from an older study that compares pulse ox screening for congenital heart disease to screening for other defects. And while some of the numbers can be debated, the general point of this slide is important. Critical congenital heart disease, or as they term it, CCVM, on this slide, occurs with a greater frequency than other screened conditions like hypothyroidism and phenylketonuria, less so than congenital hearing loss. Importantly, the positive predictive value of the test, in other words, the likelihood that a positive screen occurs in a baby with congenital heart disease is significantly higher than in hypothyroidism and hearing loss. The cost of screening for congenital heart disease compares favorably to hypothyroidism and phenylketonuria and is considerably less than for congenital hearing loss, particularly when you look at the cost per confirmed diagnosis, which can be in the $10,000 to $100,000 range for the other conditions. And the results of a delayed or a missed diagnosis are quite significant. A congenital heart defect can result in death or important neurologic injury. And again, that compares favorably to the other conditions. So we're going to talk about some examples of hearts that have important defects that we screen for. But let's start with a diagram of a normal heart, and we'll review why pulse oximetry screening works. So this is a diagram of a normal heart. The right side of the heart, which is in blue, receives low oxygen-containing blood back from the body's circulation and pumps that blood out to the lungs. The blood picks up oxygen in the lungs and returns to the left side of the heart, which is depicted here in red. This highly oxygenated blood is then pumped to the left, from the left side of the body to the aorta and then distributed to the entire body. A pulse oximeter attached to the right hand and also to either foot would then pick up that highly oxygenated blood as 100% saturated in this example. So pulse ox screening tries to identify these 7 congenital heart defects. These are all critical heart defects that can result in mortality and morbidity if not picked up early in life. So these are hypoplastic left heart syndrome, pulmonary atresia, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, and tricuspid atresia, and truncus arteriosus. So let's take one example. Here's a diagram that shows hypoplastic left heart syndrome. In this condition, there is a critical underdevelopment of the left side of the heart. Thus, the red blood returning from the lungs cannot traverse the left side of the heart. Instead, it goes across a hole in the wall between the top 2 chambers and mixes there with poorly oxygenated blue blood that is returned from the body. The result of this is blood of mixed or intermediate saturation, indicated in this diagram as purple. That purple blood is then pumped by the right side of the heart out to both the lungs and the body by way of the PDA, which is an artery present at birth and indicated in this diagram with the arrow. That artery goes away in the first couple of days of life. So a pulse oximeter attached to the right hand and the foot of this patient would pick up an oxygen saturation, for example, of 85%. Here's another example. This is transposition of the great arteries. In this diagram, there's also a narrowing of the aortic arch, but that's not too important for our discussion today. So in this condition, both great arteries, which are the aorta and the pulmonary artery, have developed incorrectly. So the aorta, or the body artery, in this diagram, comes off the right side of the heart. These positions of the heart are colored in blue. This is poorly oxygenated blood that returns from the body and immediately is pumped back out to the body. The pulmonary artery, or lung artery, here is in red. It comes off the left side of the heart. So it receives highly oxygenated blood from the lungs and pumps it back to the lungs. And in this diagram, across that PDA artery to the lower body. So a pulse oximeter in this scenario would pick up a low oxygen saturation in the right hand and a high oxygen saturation in the foot. Let's look at one other screening target. This is total anomalous pulmonary venous return, or TAPVR. In this condition, the red blood returning from the lungs is diverted by way of an abnormal or anomalous connection that runs up to the great veins above the heart. At that location, the red blood from the lungs and the blue blood from the body mix, and this again produces blood of intermediate saturation, indicated here by the color purple. So there is purple blood inside the heart that is pumped by way of the aorta out to the body, and a pulse oximeter in the right hand and either foot would both detect oxygen saturation of 85%, for example. Finally, truncus arteriosus is another screening target. In this condition, there's only a single great artery coming off the aorta. This artery eventually divides into the aorta and main pulmonary artery. Inside the heart, the red and blue blood mixed due to the presence of holes inside the atrial and ventricular walls. This results, again, in intermediate saturation blood, indicated here as purple, and that purple blood is pumped out to the lungs and to the body. So a pulse oximeter would again pick up an oxygen saturation of 85% in the hand and in either foot. So with any screening test, we want to be sure that the test performs well. In this slide, we will examine infants that screen positive. In other words, they have low oxygen saturation levels or an important hand-foot difference, but do not have one of the 7 critical congenital heart screening target conditions. Importantly, some of these babies may have other important cardiac conditions which are not technically screening targets, but still can be potentially life-threatening if not detected in a timely fashion. And in this table, taken from an article, we can see at the top of that table the category Other Critical Congenital Heart Disease, and that accounted for about 6% of the false positive screens. In other words, the screens that were positive without one of those 7 target conditions. There were also other milder congenital heart defects that were picked up in about 14% of those false positive screens. In addition, some of the babies who screened positive actually had pulmonary hypertension, infection, or lung problems, all of which may require further management and treatment in the newborn period. And lastly, and importantly, about half of the false positives in this study were actually infants who were completely normal or who had a transitional circulation which would end up being normal as well. We're going to look at some data from another study. So this graph is taken from a meta-analysis, which is really an aggregation of about 11 different pulse oximeter screening studies. And while these studies have some differences in their methodologies, when you pull the data together, you do get some important points that I would like to review. So, I'd like to highlight first the overall sensitivity for detecting critical congenital heart disease was about 77%. It's that the top line under the sensitivity column. The false positive rate to the right of that is low at 0.14%. Importantly, in the next couple lines, testing done after 24 hours of life dropped the false positive rate to 0.05, which was significantly lower than testing in the first day of life. Also, there were not enough patients to determine whether testing in the foot and right hand was associated with better sensitivity or false positive rates than checking in the foot alone. But if you look at the studies individually, there are certainly some defects that were picked up by foot and hand testing that would have been missed by foot alone. Interestingly, the false positive rate using physical examination alone is 10 times higher than pulse ox screening. That being said, pulse ox screening needs to function in complement to a good history and physical, since signs and symptoms of critical congenital heart disease can present before screening. So we'll look at results from one other study. This is a study from over 10 years ago, but it's a study that helped convince this country to adopt pulse oximetry screening. So this is a study out of Sweden, where they had certain regions of their country that took part in pulse oximetry screening and other regions that did not. So if you look at births in the non-screening regions, they had significantly higher rates of bad outcomes. Those outcomes were leaving the hospital with undiagnosed critical congenital heart disease. That happened only 8% of the time in screening regions, but it happened 28% of the time in non-screening regions. Having a diagnosis of severe acidosis, which generally portends a poor outcome, occurred in only 12% of the screening regions, but 33% of the non-screening regions. Not obtaining a timely diagnosis. This only occurred 18% of the time in screening regions and 45% of the time in non-screening regions. And what we all fear, death from undiagnosed congenital heart disease, did not occur in the screening regions, but occurred 5% of the time in the non-screening regions. And then looked at another way, babies who had their congenital heart disease diagnosed by or before pulse ox screening had a very low mortality, about 1%. And they had severe acidosis at diagnosis infrequently, about 18% of the time, compared to babies who did not have their heart disease diagnosed, at least by pulse ox screening time. And they ended up having an 18% mortality, and about 50% of them had severe acidosis at the time of diagnosis. So this is a table taken from a study done here in the United States and published in JAMA in 2017. Again, I apologize for the small print. I'll just highlight one thing from this slide. Now that congenital heart disease screening has been in practice for 10 years, researchers can go back and study the actual results of the study of this screening. And so in this study, the researchers looked back in the era from 2007 to 2013, which allowed them to analyze mortality from critical congenital heart disease during the pre-screening era and early screening area, when there were only a small number of states that mandated screening. They found that a 33% decline, which is a top number in the middle column, in the death rate from critical congenital heart disease in states with early mandatory screening policies, and no decline in the other states without screening policies. This study would suggest a real, tangible benefit from adoption of pulse oximetry screening. So there are some limitations and problems with pulse oximetry screening. First of all, there are false positives, which we've talked about already. There are also false negatives that we will get to momentarily. Importantly, pulse ox screening does not screen for certain critical congenital heart defects. The algorithm itself can be a little bit complex when first looked at. There is some cost associated with pulse oximetry equipment, training of hospital staff, and follow-up. Pulse oximetry is not reimbursed. Finally, we have to be certain we have a method in place for electronic reporting, tracking, and quality assurance. In this slide, and again I apologize for the small print, we break down the way that specific congenital heart defects are diagnosed or missed. So for example, if we look all the way to the left, HLHS or hypoplastic left heart syndrome, we can see that over half of cases are diagnosed prenatally. That's the darkest shade of gray toward the bottom. And then above that, we see that 1/3 of HLHS is diagnosed clinically after birth. About 12% of these babies are picked up by critical congenital heart disease pulse ox screening, which is a portion of the column in black. And then 2% are missed by screening, which is a portion near the very top in white. The slide nicely shows that missed screening, again the portion in white, is most problematic in some of the other columns, notably the third column from the right, which is coarctation or interrupted aortic arch. And so missed screening occurs in about 1/3 of the babies in that condition. That is not a screening target. And also in tetralogy of Fallot, which is towards the middle of these columns, at about 15 to 20%. So those portions in white would be the false negatives of screening if those two conditions were the targets. The portion in white for certain columns like transposition, TAPVR, truncus arteriosus, pulmonary atresia, HLHS, or the left half of those columns are the actual false negatives for our screening program. And we've certainly experienced this at UAB. We've had many babies who have been picked up by pulse oximetry screening and go on to have their therapy at UAB and Children's of Alabama with good results. We've also had some who've had their heart conditions missed. So this is an example of a false negative screen. This baby screened at a 98% O2 saturation in the right hand and the foot. However, this is an example of a screening violation. This baby was screened on day of life 3. The recommendation is 24 to 48 hours. So a few weeks later, this infant was diagnosed with truncus arteriosus at 5 weeks old. The baby ended up coming to Children's of Alabama and doing fine, had a good surgical outcome. But it's important to note, historically, that the mean age of death of truncus arteriosus before the area of surgical repair was 5 weeks old. This baby was fortunate not to have had a major problem before age 5 weeks. And it's important to understand how pulse oximetry can miss some of these important heart conditions. So this is a modified diagram for hypoplastic left heart syndrome. After the first day of life, the resistance to blood in the lungs that is naturally found at birth decreases. And this encourages and results in a lot more blood flow circulating through the lungs and less blood flow circulating through the body. So in this cartoon, as indicated by the PDA, which is narrowing and permitting a small line of red blood cells to exit the lung artery and go out to the aorta and the body, that small amount of blood returns from the body back to the right side of the heart as blue blood. But that is a much lower quantity of blue blood than the quantity of blood flow through the lungs, which is indicated in this diagram again as red. Mixing a lot of a lot of red blood with very little blue blood results essentially in normally or highly saturated red blood being ejected by the right side of the heart, with some of that again going out to the body. And so pulse oximetry screening in this baby would show a saturation of 98 to 100% in the body, even though this baby's on the precipice of becoming very sick. So this is the Alabama pulse oximetry screening algorithm. And again, I apologize for the small print. I'll highlight a couple points from this algorithm. On the left hand of the screening algorithm, there's the immediate fail category. A pulse oximetry reading less than 90 in the right hand or foot at any time would result in an immediate fail and notification of the clinician. In the middle column, a pulse ox reading of 90 to 94 in the right hand and foot, or a difference of 4 or more between the hand and the foot would result in a failed screen that would need to be repeated in 1 hour. If it fails again, it is repeated again, and then if it has failed a third time, the clinician is notified. What happens next is that there needs to be a comprehensive evaluation for causes of hypoxia, including infectious and pulmonary pathology. And perhaps consultation is needed with a cardiologist or a neonatologist to arrange for a diagnostic echocardiogram to be interpreted by a pediatric cardiologist. This may require telemedicine, maybe transfer to a neonatal intensive care unit, or perhaps discharge with timely outpatient echocardiography scheduled. That concludes my portion of the talk. I have some references here.
Thank you, Dr. Carlo. Again, my name is Rachel Montgomery, and I work with the Alabama Newborn Screening Program. It's with the Bureau of Family Health Services, and I'm going to be speaking today regarding newborn screening to identify critical congenital heart disease, or as Dr. Carlo said, CCHD. So I do have no disclosures in relation to this program. And my learning objective for today is going to be to describe pulse oximetry screening used to identify babies with a critical congenital heart defect, to include screening, information regarding the equipment, training, and reporting requirements. First, the mission statement for the newborn screening program is that all babies born in Alabama receive a newborn screen, and any baby with a abnormal or presumptive positive result is tracked to ensure that that baby has the opportunity for life-saving treatment and intervention as soon as possible. And so first, newborn screening is a public health service. It can impact a baby's life, and it includes, like Dr. Carlo mentioned, the blood spot screen, the hearing screen to detect hearing loss, and then the pulse oximetry screen to detect the critical congenital heart disease. Newborn screening is also the practice of testing all babies for certain harmful or potentially fatal genetic, hormonal, or congenital disorders that are typically not apparent at birth. And then the newborn screen, it's not intended to be diagnostic. So a baby that has a abnormal result must undergo further testing and clinical evaluation. And as Dr. Carlo said, that may include an echocardiogram for babies that fail their pulse ox screen. So pulse oximetry screening, again, it's a simple, non-invasive, and painless test, and it's used to measure how much oxygen is in the blood. It can also help identify a baby with congenital heart disease before leaving the hospital. And it's often thought to be a basic vital sign, I think often referred to as the fifth vital sign. And again, a normal pulse ox reading in a healthy baby is an oxygen saturation level of 95 to 100%. And again, as Dr. Carlo mentioned, congenital heart disease, or CHD, it's the most common birth defect, and it results in a problem with the structure and the function of the heart that can lead to improper blood flow through the heart. And it does require treatment, usually surgical intervention in the first year of life, and the causes are not always known. And then again, the critical congenital heart disease, or CCHD, as Dr. Carlo mentioned, there are 7 defects classified as a CCHD. And these, again, are defects that can lead to low levels of oxygen in a baby, and that can be identified using the pulse oximetry screening. Again, they include hypoplastic left heart syndrome, pulmonary atresia with intact septum, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, tricuspid atresia, and truncus arteriosus. So why is pulse ox screening used to detect congenital heart defects? I know Dr. Carlo mentioned the effectiveness of pulse ox screening. Again, it is a simple and non-invasive method, and one of the only methods used to screen for CHD. And again, it's recommended by the U.S. Department of Health and Human Services, as well as the American Academy of Pediatrics and the American College of Cardiology. And physical examination is only 50% effective in detecting CHDs after a baby is born. So the pulse ox screen can reduce the risk of morbidity and mortality, as Dr. Carlo mentioned. So did you know that newborn screening is one of the most significant life-saving public health achievements of the 20th century? This is according to the Centers for Disease Control and Prevention, and it's because newborn screening does result in life-saving treatment and intervention for approximately 12,000 babies born in the United States each year. And then again, about 1 in 125 babies have a congenital heart defect. And so CCHD was first nominated in October of 2009 to be added to the recommended uniform screening panel. And then in January of 2010, the Advisory Committee on Inheritable Disorders in Newborns and Children reviewed and approved CCHD to go through evidence review, which it did in May of 2010. And then in September of that year, it was approved by the committee to be added to the recommended uniform screening panel. And then a year later, the U.S. Secretary of Health and Human Services approved CCHD to the RUSP, or Recommended Uniform Screening Panel. So that's when all states began considering adding pulse ox screening to their newborn screening panels. And Alabama was one of the first states to look at implementing pulse ox screening to detect CCHD. We did convene a work group in November of 2011 and again in December. And that work group consisted of pediatric cardiologists, neonatologists, as well as other healthcare professionals, and some agencies such as Medicaid and the Alabama Hospital Association. Most of our hospitals did implement screening voluntarily in April of 2012, and then it was officially added to the Alabama panel on June 21st of 2013 and became required by state law. And so in May of 2012, we did develop hospital guidelines for implementing pulse ox screening to detect critical congenital heart disease. These guidelines were adapted from Children's National Medical Center CCHD screening toolkit. And the purpose was to provide information for screening, training, and reporting results. And these guidelines can be found on the newborn screening website at www.alabamapublichealth.gov/newborn screening. And so included in the guidelines is information regarding the screening equipment. So the pulse oximeter equipment should be compliant with the national standards and adhere to the following. Of course, the pulse oximeter should be motion tolerant and report the functional oxygen saturation. It should also be validated in low perfusion conditions. Should be cleared by the FDA for use in newborns. And it should have a 2% root mean square accuracy. And then it also should be calibrated regularly based on the manufacturer guidelines. And then as far as training, the guidelines includes information regarding training and recommends that the training be performed by qualified personnel, and it should be hands-on and competency-based, and include an overview of the screening protocol, education on the use, care, maintenance, and troubleshooting of the equipment, a review of the general nursery policies and procedures. In addition, it should include education on the differences between adult and pediatric oximeter probes, an explanation on the importance of adequate circulation, effects of hypothermia and phototherapy on pulse ox results or screening, and then finally resources for pediatric echocardiogram. That was an issue initially when we began implementing pulse ox screening. As many rural hospitals, that question came up because there wasn't the availability of pediatric echocardiogram. So that information was obtained and provided. And then additionally, it includes education program components to include the pulse ox probe placement education, do's and don'ts for providers, and then a knowledge assessment quiz for screeners, and then finally the competency checklist for screeners. And then so some of the things that the screener should do when performing the pulse ox screening: if they're using disposable probes, they should be sure to use a new clean probe for each infant. And if using the reusable probes, they should be sure to clean the probe with the recommended disinfectant solution between each infant. And then again, the best sites, as Dr. Carlo mentioned, is around the palm of the right hand and either foot. And then there should be no gaps between the sensor and the baby's skin. Also, the screener should ensure that the infant is calm and warm during the screening. It is recommended that the baby be awake when performing this screening, but I don't think that's always necessary. And then it may be helpful for the screener to swaddle the infant and then encourage the family to be involved in order to promote comfort. Because you do want a calm baby and not a baby that's crying or kicking. And then some things that the screener should avoid when performing the pulse oximetry screening. Of course, they should not use an adult pulse ox sensor when obtaining a pulse ox reading for an infant. So you want to be sure to use an infant pulse ox sensor. You should never attempt to attain a pulse ox reading on the same extremity that there's an automatic blood pressure cuff. And the screener should ensure that the baby is not placed in bright or infrared light while pulse ox is being performed. And then they would need to avoid using tape to apply the pulse ox probe to the baby's skin. And so they also just mentioned for the screener to be mindful that the pulse is needed to determine the oximetry reading. So the pulse ox is not accurate if the baby is coding or is having a cardiac arrhythmia. So remember, if there's no pulse, then there's no oximetry. And then it's also helpful to keep in mind that pulse ox readings are not instantaneous. So the oximetry reading that is displayed on the monitor, it's an average of readings over the past few seconds. As far as supplies needed to perform the pulse ox screening, of course, you would need a pulse oximeter, again, that is motion tolerant and FDA approved. Again, using either the infant disposable or reusable pulse ox sensors. And it may be helpful to have a rolling cart available to gather the supplies. And then the screener would need to have either the data collection form or the newborn screening reporting form available to document the screening results. And it is, again, recommended that trained staff perform the pulse ox screening. It may be helpful to have blankets for warming the baby or blocking light. And then, again, it's encouraged for the family to be involved for comforting the infant during the screening. So as Dr. Carlo mentioned, that it is recommended to perform the pulse ox screening between 24 and 48 hours of age. So the screener should confirm that the baby is between 24 and 48 hours of age. Again, it's helpful to have the parent available to warm and calm the baby. The baby should also be on room air and not receiving any supplemental oxygen when performing the pulse ox screening. And then, again, a site on the right hand and 1 foot should be selected that is clean and dry. And then the screener would then place the pulse ox probe on the baby and perform the pulse ox test. And again, this is the pulse oximetry screening protocol diagram that Dr. Carlo reviewed. I just want to mention again that this screening algorithm, it should not take the place of clinical judgment or customary clinical practice. And as he referenced, just because a baby passes the screen does not rule out a heart disease. And so he's previously mentioned that a baby with an immediate fail would have a pulse ox saturation level less than 90%. Again, the screener would want to notify the doctor caring for that baby immediately, and again, perform immediate evaluation for causes of hypoxemia, including infectious and pulmonary pathology. And then if there's no other etiology found, it's recommended an immediate echocardiogram to be interpreted by a pediatric cardiologist. And then the screener should finally report those failed results to public health as required by state law. So there is a reporting form available in the guidelines. It's also can be found on the newborn screening website. So it is recommended that screeners use this form to document the screening results. There's an area on the form to place a patient label, or the screener can fill in the demographic information. And again, this reporting form should be submitted to the Alabama Department of Public Health at the fax number shown, which is 334-206-3791. And I know that Dr. Carlo mentioned other methods for screening, looking at electronic means for reporting results. And we are exploring other methods for reporting other than the submission of this reporting form. I know many hospitals have taken this form and adapted it, and it's a part of their electronic health record. And there are other tools available for when performing the pulse ox screen. We do have some other resources on our website, including a pulse ox screening tool that can be found also at pulseoxtool.com. It was created by the Children's Healthcare System in Atlanta, and it's a helpful tool to have. They also have an app available where the screener can put in the results, and it will automatically let them know what the next steps should be in the process. So again, a failed result is a pulse ox reading of 90 to 94%. And as Dr. Carlo mentioned, that should be repeated by the screener. If the baby fails for a second time, then again, they should repeat the screen for a third time in an hour. And finally, if that baby fails that third time, the screener should notify the doctor caring for the baby immediately and then perform evaluation for other causes. And if there are no other causes found, then they should consult with a pediatric cardiologist or neonatologist as indicated for diagnostic echocardiogram, again to be interpreted by a pediatric cardiologist. And then of course report those results to public health. And so the Association of Public Health Laboratories published data on critical congenital heart disease in the United States. This was data that was entered into the New Steps data repository. And so included in that publication was information regarding newborn screening in the United States. So currently, all 50 states have implemented universal screening for CCHD, including some U.S. territories. And then this graph here is a distribution of the CCHD diagnoses from 2012 to 2018. Again, you can see some of the more common congenital heart diseases identified include tetralogy of Fallot, total anomalous pulmonary venous connection, and then also hypoplastic left heart syndrome and the transposition of the great arteries. And then here is a slide. This is Alabama CCHD cases that have been reported to public health since we implemented screening in 2012. So we've had 12 cases between 2012 and 2018 that failed the pulse ox screen and were identified with a congenital heart disease. And you can see here, it's interesting because one of the ones that we've picked up is the coarctation of the aorta, and I know you mentioned that that was one that may have high false negatives for that, but we've picked up 4 of those through the pulse ox screen. And then we've had a few cases where the babies did pass the pulse ox screen and again were later identified with a congenital heart disease. We've had a few false negatives, and I didn't list all the false positives we've had, but of course we've had several false positives. And so at this time I'm going to show a brief video. This is a video that was developed by Children's National Medical Center in conjunction with Baby's First Test, and it is an overview of CCHD screening.
Pulse oximetry is a simple, painless, inexpensive means to help us detect critical congenital heart disease.
Screening for critical congenital heart disease using pulse oximetry can improve outcomes and save lives.
The goal would be for every hospital and birthing center in the country to screen babies, and that is what the pulse ox test is looking for.
Pulse oximetry, called pulse ox for short, is a simple, painless, and non-invasive test that helps identify babies with heart defects known as congenital heart disease, or CHD, the #1 birth defect in children. Pulse ox is just one of several tools medical professionals use to help identify newborns with serious heart problems before they ever leave the nursery. Many leading health organizations have endorsed adding screening for critical congenital heart disease to the recommended uniform screening panel.
This is going to be a game changer for us. And now we're just going to have a little bit more safety for those babies when they're born so that we find them and get them to early treatment, and that will improve the lives of many babies.
I tell families that it's an easy, it's a painless, and it's a very quick way to detect for the presence of CCHD in their newborn.
My daughter, Veronica, died suddenly and unexpectedly when she was 7 weeks old of an undiagnosed congenital heart defect that could have been picked up had she received screening when she was born. She appeared perfectly healthy. I had all the prenatal tests, including a 20-week ultrasound. Everything was normal, so we were under the impression that she was a perfectly healthy baby with a perfect heart. She died suddenly. They found that she had this heart defect that could have been fixed surgically had we known about it. So when I learned about pulse oximetry screening, that this could have been done, it really made me angry that she had not been screened. I hope that one day all babies are tested before they leave the hospital so that no baby dies from a treatable condition the way my daughter did.
CCHD screening should be done at or as close to 24 hours of age as possible. We screen the right hand and the right foot. They perform a pulse ox measurement on both of those.
The pulse ox screening measures your baby's blood oxygen levels. If the levels are normal, that's all there is to it. If the levels fall below the normal range, the test will be conducted more times to ensure accuracy and an average reading. If the pulse oxygen levels recorded are lower than normal, your baby will be rescreened, because sometimes babies take time to adjust to breathing outside the womb.
If a screen does not give the results that we are looking for, we do multiple screens. If at the end of those multiple screens the results are still not what we want, we are in touch with the baby's pediatrician and they determine what the next course of action is.
The goal is to be sure to catch any concerns for your baby's health before he or she leaves the hospital. Of course, no screening can catch all heart defects or other issues. If you notice that your baby has any of the following signs or symptoms of CHD, be sure to consult your pediatrician immediately.
We think that it's so important to catch babies that have any treatable condition early. So in addition to the heel stick, in addition to the hearing screening, we think that CCHD screening fits in so nicely because we can save babies' lives, and that's huge.
Approximately 8 of every 1,000 infants born have a form of CHD. While this screening can't detect all forms of CHD, it helps with early identification of some at-risk babies.
Our goal ultimately is that no baby with critical congenital heart disease will leave a nursery and not be treated for a condition in which we have excellent results.
We want all newborns that are leaving the hospital to have access to this CCHD test, and we have tried to show that that's possible.
We really want parents and providers to know that CCHD screening using pulse oximetry can improve outcomes and potentially save lives.
This is just another test in the panel that is for the benefit of your baby, to give your baby the best chance at living a long, healthy life.
To learn more about CCHD screening using the pulse ox test, ask your health team. You can also go to www.babiesfirsttest.org.
So that concludes my presentation for today's program. So I'm going to turn it back over to Leanna to see if we have any questions.
We don't have any questions right now. Do we have some that we want to share?
Yeah, I do have a question for Dr. Carlo regarding prenatal testing, prenatal screening. So I know that many babies are identified prenatally with congenital heart disease, and so I was just curious as to how many get picked up prenatally.
It's a good question, and it varies by condition, but probably somewhere in the ballpark of a half to 2/3 of congenital heart defects are picked up prenatally, usually by the routine ultrasound screening done by the OBGYN doctors halfway through pregnancy. For some conditions, it's much more easy to diagnose prenatally. For others, it's very challenging. It would be my wish that 100% of the defects could be picked up prenatally, such that screening weren't needed, but that's not the case. And because a significant number of babies are stillborn and their heart condition is not detected prenatally, this is why pulse ox screening is vital for this group of babies, and it does save lives and it does improve outcomes in those who screen positive.
Thank you. So any other questions that have come in?
Yeah, we have one question. Is it okay for the mom to hold the baby during the screening?
Yeah, and that actually, I did mention that it is helpful, again, to have the parents involved in holding the baby to keep the baby calm and keep the baby warm. So that is actually encouraged during the pulse ox screening.
Okay. Do we have any more? I don't have a list of questions.
Okay. Well, I appreciate it. Thank you, Dr. Carlo, for taking time to be with us today and sharing information about critical congenital heart disease.
Thank you for the invitation.
This concludes our program for today. I want to thank Dr. Carlo and Rachel for being here, and thank you for watching. Please remember that you can refer back to the training and resources anytime on demand. That's it.